Okay. Uh, Good evening. My name is Nikolai Kasi, currently at San Fernando General Hospital Neurosurgical Department. Today I'll be presenting on glioneuronal and neuronal tumors. So firstly, we start with gangliogliomas. All right, this is just some general information to get us started with. This type of tumor is a WHO grade 1 type tumor. First described by Colville 1930, the term ganglioglioma was introduced to define neoplasms containing both astrocytic and neuronal components. They are well-circumscribed tumors composed of two cell types, the ganglion cells and the glial cells, characterized by its slow development and propensity to calcify. Although rare, they are most frequently occurring mixed glioneuronal tumors of the central nervous system corresponding to the WHO1 and rarely the 2. Their incidence range from 0.4 to 1.3% of all brain tumors, but they are more commonly pediatric group with an incidence of 7.6%, diagnosed primarily in the first 3 decades of life, with a mean male to female periodic lactation 1.3 to 1. The temporal lobes are known to be the most common site of these types of tumors and can occur anywhere in the central neural axis, including the brain stem as well as the spinal cord. I'll go through briefly some clinical presentations of with patients with these tumors. So these tumors usually present in the temporal lobe, as previously stated, and as such, patients usually present with temporal lobe um, epilepsy. Patients also present with cerebral tumors, can have headaches, hydrocephalus, and associated symptoms, truncal ataxia, gait disturbances, and appendicular dyssymmetry. Brainstem tumors can often lead to dizziness, nausea, vomiting, and even hemiparesis. Spinal cord gangliogliomas are rare in adults and can present with paraparesis and radicular type pain. Here's the diagnostic criteria for these types of tumors. So firstly, an essential finding would be an intraaxial low-grade glioneuronal tumor with a combination of neoplastic ganglion and glial cells. And for unresolved lesions, you may find the BRAFP valine 600E mutation or the MAPK pathway alteration, or even methylation profile of ganglioma. What would be a desirable finding in this type of tumor is the absence of the IDH mutation. So here we have two MRI images to describe these types of tumors. These imaging findings mirror the various patterns of growth which these tumors demonstrate, and thus their appearances are very variable. A partially cystic mass with an enhancing mural nodule is seen in approximately 45% of cases. They may also simply present as a solid mass, expanding the overlying gyrus, and an infiltrating mass is uncommon and may reflect a higher grade. So regarding CT and MRI, the temporal lobe, as previously mentioned, is quite favored. Mass effect is rare, and this suggests that these types of tumors have a predominantly slow rate of growth. Enhancement varies from none to hyperintense. Some more details here regarding CT is that tumor calcification are best appreciated on CT and are seen in approximately 35% of cases. You may find bony remodeling or thinning an indication the slow growing nature of the tumor. Enhancement is seen in approximately 50% of cases involving the solid, non-calcified components. With regard to MRIs, reported signal characteristics include T1, W1 will be low to isointense with variable enhancement. The T2 hyperintense calcifications appear as the low-grade signal in both. Um, T1 solid component is ISO2 hypointense, and T1 with gadolinium, you may find solid component variable contrast enhancement. With regards to the T2, hyperintense solid components, as previously described, variable signal in the cystic component depending on the amount of proteinaceous material or the presence of blood products. Um, Peritumoral flare slash T2 edema is distinctly uncommon of these types of tumors. So, regarding treatment and prognosis of these tumors, the treatment recommendation is a maximum safe resection. Close follow-up is recommended, and re-resection should be reconsidered if there are reoccurrences. In contrast, when resection is not possible due to a location, example, in the spinal cord, tumor progression is quite common. The role of radiotherapy is unknown at present, and due to the deleterious effects together with the good long-term prognosis, it is recommended initially, but may be considered for may consider reoccurrence. Prognosis otherwise, these benign tumors, they have a 97%, 7.5-year reoccurrence free survival rates. Prognosis is better with the temporal lobe location when availability to do a gross total resection in this area, and patients usually have chronic epilepsy following this. The prognosis following subtotal resection of the brainstem gangliomas is better than the brainstem gliomas as a group entirely. Okay, so moving on to the second one is gangliocytoma, which is a WHO grade 1 as well. So this is a rare, slow-growing, well-differentiated WHO grade 1 tumor that primarily affects children, characterized by clusters of neoplastic ganglion cells, frequently with dysplastic features. As with gangliogliomas, the gangliocytomas can occur anywhere in the CNS and the central neuraxis. Most occur above the tentorium, primarily in the temporal lobe, approximately greater than 70%, or near the third ventricle, in the hypothalamus or in the frontal lobes. They have also been described in the pituitary region as well. The key features in distinguishing the gangliocytomas from the gangliogliomas is the identifying a lack of neoplastic glial cells. Similarly, ensuring no neoblasts are seen is important to exclude more aggressive tumors, such as the medulloblastoma and neuroblastoma, which can have similar appearing ganglion cells. They are considered one of the long-term epilepsy-associated tumor, also known as deletes. The clinical presentation of the gangliocytomas, there's practically no clinical difference between both of them. But however, symptoms will overlap, and for most of these type of neuroglioma and neuronal tumors, the symptoms are quite similar. So if you find these tumors from prevalent in the cerebral hemispheres, you again seizures, patient presents with headaches, neurological deficits, as in weakness, speech problems, cognitive and behavioral changes, cerebellar signs, cranial nerve deficits, and sometimes increased intracranial pressure based on the presence of blocking the aqueducts and the ventricular systems. So this is the diagnostic criteria for these types of tumor. What is essential is a tumor-factive lesion with the presence of a regular group of large, mature ganglion cells and matrix resembling normal neuropile, sometimes more costly, fibrillar or vacuolated. What is desirable for these types of tumors are typical and binucleated ganglion cells, or cytoplasmic ballooning or vacuolization. In terms of radiological evaluation, appearance of gangliocytomas are indistinguishable as previously mentioned from the gangliomas, they tend to occur in the cortex, most often in temporal lobes. Because of cortical location and slow growth, calvarial remodeling may also be seen in these tumors as well. In terms of CT imaging, gangliocyte tumors typically appear hyperattenuating or non-contrast enhancing. They usually have little associated mass effects and minimal or no surrounding vasogenic edema. Calcification and cyst formation can be present. Regarding MRIs, gangliocytomas often have cystic and solid components and may demonstrate calcification. With on T1, solid components typically are hypointense. T2, solid components are typically mildly hypointense, with cystic areas being hyperintense. Calcifications, and if present, can be hypointense as well. T1 plus gadolinium, this would suggest shows solid components with enhancement, and a T2 susceptibility with enhanced is you'll find signal loss due to calcifications. Regarding treatment and prognosis, these tumors tend to grow slowly and do not undergo anaplastic change, unlike gangliomas that can rarely have higher grade glial components. Resection is usually curative with a 7.5-year progression-free survival rate of 94%. Moving on to the next tumor, this will be desmoplastic infantile gangliogliomas, DIG, or desmoplastic infantile astrocytoma, DIA, both of which are grade 1 tumors. Both of them are benign, WHO grade 1 glioneuronal neural tumor with a neuroepithelial population neuroepithelial population, which is restricted to either neoplastic astrocytes only by the DIA or to astrocytes with variable mature neuronal components in the DIG in a desmoplastic stroma. The vast majority occurs in children below the age of 2 years, and males are more commonly affected with a male to female ratio of approximately 1.5 to 2 to 1. Only a handful of adult cases have been reported, again, with a male predilection. They are driven by the MAPK pathway alterations, and these tumors rarely seed through the CSF. They are rare intracranial tumors, which despite its aggressive appearance, tend to have a good prognosis and is considered WHO 1. Right? These tumors are usually heterogeneous with the solid peripheral desmoplastic component composed of meningeal tumor cells, primarily a mixture of fibroblast-like cells and neuroepithelial cells embedded with a connective tissue background. In both, the dominant neuroepithelial component composed of astrocytes. However, in the latter, neoplastic neuronal elements are also identified. Clinical presentation of these types of tumors typically presents in infants under 2 years of age, as previously described, with a rapid head growth, bulging fontanelles, and signs of increased intracranial pressure. Signs of increased intracranial pressure, as we would know, headaches, vomiting, sunset eyes, and then patients will also present with seizures, focal neurological deficits, and most times irritability. Yeah, this is the diagnostic criteria. Also, what is essential here is a biphasic morphology with a dominant desmoplastic leptomeningeal component admixed with neuroepithelial component containing astrocytic cells. Only in the DIA or containing astrocytes and neuronal cells in the desmoplastic infantile gangliogliomas. For unresolved lesions, metallation profile of both tumors can be seen, or presence of the BRAF or RAF1 mutation or fusion occurring in the absence of a homozygous deletion of the CDKN2A or CDKN2B gene. What can be a desirable finding would be tumors with a cystic component and a solid portion with leptomeningeal involvement, usually attached to the dura. Infantile onset, typically below 24 months old. When investigating radiologically, both tumors manifest as exceptionally large cerebral hemispheric masses composed of both cystic and solid portions, usually more cystic with a mural nodule involving both cortex and meninges. The frontal and parietal lobes are most common sites for these types of tumors. So with regards to CT, the solid portion of these masses is typically slightly hyper-attenuating to brain parenchyma and usually located along the cortical margins of the mass. Following administration of contrast, the solid portion usually enhances intensely and may demonstrate a dural tail. Calcification is variably reported, uncommon in some series and up to approximately 50% in others. MRI would usually show a solid portion, typically have the following signal intensities. So T1 and T2 would be both in iso-intense to the brain parenchyma and with gadolinium, intense enhancements, and a dural tail may be seen. Apologies, I could have found a better image in displaying the dural tail. So basically, around here, it would be an extension from the cortical region. So an extension coming this way, similar to what is seen here. So moving on to treatment and prognosis. So prognosis is usually favorable with a gross total resection with no relapse in 5 to 15 years of follow-up. They can rarely recur with anaplastic transformation as long as 8 to 10 years after initial resection. And the response to resection is quite promising. However, because of the large size of these lesions and the firm attachment to the dura, complete resection is difficult and a significant rate of perioperative mortality can result from attempted surgical excision. In cases of partial resection, adjunctive chemotherapy may be considered and has been reported to produce some reduction in tumor volume. Moving on to the next tumor, this would be this embryoplastic neuroepithelial tumor, also referred to as DNT. Right, this is also a WHO grade 1 type tumor. They are benign, slow-growing glioneuronal tumors arising from either the cortical or deep gray matter based in the temporal lobe of children and young adults, and are frequently associated with cortical dysplasia in up to 80% of cases. They are considered part of the heterogeneous group of tumors known as long-term epilepsy-associated tumors, LEATS. In 90% of cases, the first seizure occurred before the age of 20. Only a slight male predilectation is present. Association with Noonan syndrome has been proposed. They are characterized by multinodular architecture with neuroglial columns, with a pathognomic glioneuronal element, thought to arise embryologically from the secondary germinal layer, which includes the subependymal layer, cerebellar external granular layer, hippocampal dentate fascia, and subpapillary granular layer. Most DNTs are sporadic and result from FGFR1 alterations present in 40% to 80% of DNTs, which upregulates the MAPK and PI3K pathways. BRAF and p-valine 600 mutations are found in up to 50% of some of these cases. In terms of clinical presentation with a bit of histology. So these patients, the vast majority, 90% of DNET, present with long-standing treatment, resistant focal epilepsy without associated or progressive focal neurological deficit. Yeah. Histologically, DNETs are a mixed glioneuronal neoplasm with a multinodular architecture and a heterogeneous cellular composition. The specific glioneuronal element, also known as the SGNE, is characteristic and refers to columnar bundles of axons surrounded by oligodendrocyte-like cells which are oriented at right angles to the overlying cortical surface. Between these columns are floating neurons, as well as stellate astrocytes. Three distinct forms of the SGNE described, which is one, the simple form. The glioneuronal elements consisting of the axon bundles perpendicular to the cortical surface, with lined with oligodendroglial-like cell that's S100 positive and GFAP negative. Normal appearing neurons floating in a pale eosinophilic matrix scattered between these columns, no resemblance to ganglion cells, unlike gangliogliomas. The second one, the complex forms SGNE with glial nodules and a multinodular architecture. The glial component may mimic a low-grade fibrillary astrocyte tumor with foci of the cortical dysplasia occurring. Non-specific type SGNE with no SGNE, sorry, but otherwise the clinical and neuroimaging features as complex DNETs are seen. With regards to the diagnostic criteria, uh, what is essential is the presence of cortical glioneuronal tumor and presence of the specific glioneuronal elements. And for unresolved lesions, the FGFR1 gene alteration um, with regards to the internal tandem duplication, fusion, missense mutation, or the methylation profile of this embryoplastic neuroepithelial tumor. What is desired in these type of tumors is early onset focal epilepsy. So touching a bit on the radiological evaluation of these types of tumors. So with CTs, DNS appear as low density masses, usually with no or minimal enhancement. When cortical, as is usually the case, they may scallop or remodel the inner table of the skull vault, but without erosion. Calcification is visible in approximately 30% and is typically visualized in the deepest part of the tumor, particularly adjacent to the enhancing or hemorrhagic areas. With MRIs typically seen as a cortical lesion with hardly any surrounding vasogenic edema. With T1, generally hypointense compared to with adjacent brain tissue, and with gadolinium may show enhancement in approximately 20-30% of cases. Enhancement may be heterogeneous or a mural nodule. With T2, generally high signal and a classic appearance of soap bubble appearance, um, and with the flare, uh, mixed signal intensity with bright rim sign, partially suppression of some of the bubbles. The T2 calcifications are relatively frequent. Hemosiderin staining is uncommon as bleeding into DNET is only occasional or quite rare. Sometimes you can consider PET scans, which will show hypometabolic with the 18F or fluorodeoxyglucose negative uptake, unlike the other gliomas. Treatment and prognosis, they demonstrate essentially no growth over time, although gradually increasing in size has been described. Prognosis is excellent. However, due to the difficulty in managing seizures medically, patients usually undergo resection, and even in cases of incomplete resection, seizures frequently cease. Recurrence and continued growth. So regarding that, recurrence after complete removal or even tumor growth after partial resection is quite rare. And the consideration for adjuvant treatment, as in chemotherapy or radiation therapy, is thought not to offer much benefit in these type of benign tumors. Mitosis or endothelial proliferation seen on occasion do not affect outcome, and the malignant transformation is very rare. Moving on to next type of tumor, which is diffuse glioneuronal tumor with oligodendroglioma-like features and nuclear clusters, DGONC. And at present, we do have a very distinct WHO grade for these types of tumors. The exact nature of these diffuse glioneuronal tumors with oligodendroglial features and nuclear clusters has yet to be well defined. It has been proposed it should be considered a WHO grade 2 tumor. Occurs mainly in children, although higher ages of some cases of higher ages have been described. May often present as a pediatric supratentorial tumor. These types of tumors are diffuse glioneuronal tumors with oligodendroglial features, and the nuclear clusters demonstrate histological, molecular, and immunophenotype features almost overlap with other better known tumors, such as the oligodendroglioma grade 3, neurocytoma, and dysembryoplastic neuroepithelial tumor, primitive neuroectodermal tumor, and even the glioblastoma. The DGONC is a provisional entity for a neuroepithelial tumor with a variable differentiated cell, often possessing perinuclear halos, scattered multinucleated cells, and nuclear clusters, having a distinct DNA methylation profile and frequent chromosome 14 monosomy. In the small number of cases reported, all were supratentorial. On clinical presentation, these patients again often present with seizures characterized by clear cell features, perinuclear halos, nuclear clusters, and vascular proliferation, often resembling embryonal tumors radiologically. Seizure patients again will present with seizures, headaches, behavioral changes, and even vomiting. The diagnostic criteria for these types of tumors, what is essential here is the methylation profile and nuclear clusters of small to medium-sized cells exhibiting oligodendroglioma-like morphology. Also, strong expression of both OLIG2 and synaptophysin, and also lastly, absence of widespread GFAP expression. What is desirable will be the finding of a monosomy of chromosome 14. In terms of radiological evaluation, on T1, you'll find hyperintensity of around these tumors. T2 and the flare will both show hyperintense with no perilesional edema and with gadolinium, poor enhancement seen. DDWI and ADC shows central low ADC values. Regarding treatment and prognosis, data about treatment prognosis of these types of tumors are still limited due to its rarity. In the few reported cases, surgical resection was the treatment of choice with adjuvant radiation therapy and chemotherapy. Prognosis generally positive, although recurrence is possible. Outcome has shown approximately 81% of a 5-year progression-free survival and 89% 5-year overall survival rates. Moving on to the next one. So papillary Glioneuronal tumors, PGNT, also WHO grade 1, is a rare glioneuronal tumor of young adult patients. Median age of diagnosis is around 23 years, but are reported in all ages. No predilection to male or female, and PGNT are supratentorial as well, most often in the temporal lobes, approximately 28%, and frequently in proximity to the lateral ventricles. Papillary glioneuronal tumors are rare with well-circumscribed, complex solid cystic supratentorial lesion with an indolent clinical course. They are often considered part of the heterogeneous group of tumors known as the leads, a biphasic pattern and a variable manifestation of pseudopapillary glial structures and interpapillary neural components and possessing PRKCA gene fusion. Papillary glioneuronal tumors often contain both glial and neural elements, and characteristic microscopic features are hyalinized vascular pseudopapillary architecture with a pseudo-stratified layer of cuboidal glial cells and focal collections of neurocytes and ganglion cells also seen. So the diagnostic criteria for these, we find biphasic histological and immunophenotypic pattern with pseudopapillary glial lining the interpapillary neuronal components. Also the presence of PRKCA gene fusion and strong expression of both OLIG2 and synaptophysin. Also, for unresolved lesions, methylation profile of papillary glioneuronal tumors. What is desirable here is the well-delineated, solid, and cystic tumors. Of note, diagnosis should be heavily weighted towards molecular findings because the morphological analysis frequently results in mistyping. So, in terms of the radiological evaluation, they are well demarcated supratentorial solid to cystic or cystic lesions with solid nodules showing intense but heterogeneous enhancement. Mild mass effect and edema may be present. Portions may enhance with contrast with features on imaging are very similar to gangliogliomas. Calcification is a frequent finding. Hemorrhages usually seen in approximately 10% of cases and is sometimes very pronounced. Regarding the MRI findings, T1 will show isointensity to hypointensity, and T2 in homogeneously hyperintense, and on flare in homogeneously hyperintense nodule with cystic components may be suppressed. T1C plus avid but heterogeneous enhancement of the solid nodules can be seen. Treatment and prognosis. The ability to achieve gross total excision is the primary prognostic factor, and papillary glioneuronal tumors are indolent and surgical resection is usually sufficient. In cases with proliferation is high, when proliferation is high, then local recurrence has been described. Next tumor, so rosette-forming glioneuronal tumors, WHO grade 1 type tumor. This is a rare, slow-growing WHO glioneuronal tumor with two histological components, one being the uniform neurocytes forming rosettes and or perivascular pseudo-rosettes, and secondly, the glial components with hyaloid and oligodendrogliocytes-like cells resembling a pilocytic astrocytoma. Although WHO grade 1, they usually develop satellite lesions, leptomeningeal involvement, or drop nets. Rosette-forming glioneuronal tumors are quite rare, usually midline tumors that involve the fourth ventricle and or aqueduct of Sylvius. Rosette-forming glioneuronal tumors are typically diagnosed in younger adults, patients with a mean age of 30 years. There's thought to be a slight female preponderance of 1 to 1.36. In terms of clinical presentation, similar to previously described tumors with headache, ataxia, gait disturbances, nausea and vomiting, visual disturbances, vertigo and dizziness. Other symptoms can include tinnitus, lethargy, and seizures can also occur here as well, depending on the location and the size of the tumor. In terms of diagnosing this with criteria by a biphasic histomorphology with neurocytic component and a glial component, and uniform neurocytes forming rosettes and or perivascular pseudo or rosettes, pseudo rosette associated with synaptophysin expression. And for unresolved lesions, small biopsies showing only one tumor component, usually neurocytic or glial, and a methylation profile of rosette-forming glioneuronal tumors. What is desirable is a FR1 mutation with a co-occurring PIK3CA and or NF1 mutation. In terms of radiological evaluation for these types of tumors, uh, they usually tend to present as solid cystic components. When they are entirely cystic, there's around 40%. The mixed solid and cystic presents as 35% of cases, and entirely cystic, 25% of cases. On CT, these tumors are of variable appearances reflecting the solid and cystic components. Calcifications are seen in approximately 25% of cases, and these are usually hypodense. On MRI, as expected, the cystic components demonstrate a high T2 signal, whereas the solid components demonstrate a variable gadolinium enhancement. Also on MRI, appearances, as we described, variable, they are relatively well circumscribed. They tend to be hyperintense on the T2 weighted and iso to hypo-intense on the T1 with variable enhancement. So if complete resection is achievable, which depends mostly on location of the tumor, then a cure is possible to surgery alone, although due to their location, neurological deficits following resections are quite common. Treatment of choice is gross total resection when possible. Prognosis for overall survival rate is favorable, and recurrence is rare after a gross total resection. However, neurological deficits usually can be found following surgery. Malignant progression has been reported, but are quite rare and may be higher risk with subtotal resection or with purely solid lesions. RGNTs may be disseminated through the CSF. This is a histological picture just describing the rosette formation. Moving on to myxoid glioneuronal tumors, also WHO grade 1. They are a rare, low-grade glioneuronal tumor with less than 100 cases reported to date that usually occur in the septal nuclei, septum pellucidum, and corpus callosum, or even the periventricular white matter. Histologically, there's a proliferation of oligodendrocytes like neoplastic cells contained in a myxoid stroma. There's a recurrent dinucleotide mutation at codon P K385 in the PDGFRA gene. The histologic features of this tumor are similar to dysembryonic neuroepithelial tumors, and therefore they were formerly called DNETs of the septum pellucidum. It often occurs in children and young adults. This is a rare tumor with tens to hundreds of cases reported worldwide. Although it has been designated as a WHO grade 1 tumor, myxoid glioneuronal tumors tend to recur, progress, or disseminate in the ventricles. They may cause critical mass or compressive effect with resulting obstructive hydrocephalus. Clinical presentations, again, similar for these types of tumors: headache, ataxia, gait disturbance, nausea, vomiting, visual disturbance, vertigo, and similar other symptoms as tinnitus, seizures, and lethargy. The diagnostic criteria for these types of tumors: oligodendrocyte-like tumor cells embedded in a prominent myxoid stroma and with location in the septal, nuclei septal, pellucidum, corpus callosum, or periventricular white matter. A desirable outcome would be the presence of the PDGFRA-P K385L gene, or the dinucleotide mutation, or less commonly found there, other mutations in the extracellular domain of the PDGFRA. Methylation profile again of myxoid glioneural tumors. And of note, desirable diagnostic criteria can be essential for unresolved cases. When describing these tumors radiologically, they are well circumscribed tumors that are hypointense on T1 and hyperintense on T2 MRI. On SWI susceptibility artifact may be seen, suggestive of a previous hemorrhage. Septal lesions often produce obstructive hydrocephalus, and this tumor has a well-defined lobulated mass appearance. On MRI, T1 hypointense, T2 hyperintense, flare, bright rim sign like the DNETs, and on T1 gadolinium, usually no enhancement seen. Myxoid glioneural tumors, these are the usual treatments and prognosis. So data regarding these types of tumors are limited due to the rarity of the tumor. Surgical resection is often curative, although cases of recurrence, progression, and intraventricular dissemination have been described. In these cases, a second resection was frequently necessary. Only seldomly have radiotherapy and chemotherapy been used, and these type of slow-growing tumors have a favorable prognosis for overall survival. A subset may recur locally or disseminated through the CSF, but their behavior remains indolent. So moving on to the next tumor, diffuse leptomeningeal glioneuronal tumor, DLG and T, usually found as a WHO grade 2 or grade 3. These types of glioneuronal neoplasm comprise of oligodendrocytes-like cells that is characterized by chromosome ARM1P deletion and a MAPK pathway gene alteration, typically KIAA1549 or the BRAF fusion. Diffuse leptomeningeal glioneuronal tumors, previously known as the disseminated oligodendroglional-like leptomeningeal tumor of childhood, is a rare tumor of the central nervous system. It typically presents with hydrocephalus secondary to prominent leptomeningeal enhancement, often without a readily identifiable parenchymal component. These tumors are most commonly encountered in children and adolescents, with the vast majority of reported cases in individuals less than 18 years of age. Occasionally, they're encountered in young to middle-aged adults. There appears to be a moderate male predilection to these types of tumors. On clinical presentation, hydrocephalus predominates due to the pronounced accumulation of tumor within the subarachnoid spaces. Occasionally, patients may present with focal neurological symptoms, including cranial nerve impairment, ataxia, and spinal cord compression, or with seizures. Um, Hydrocephalus is a hallmark of these types of tumors, leading to symptoms of headaches, vomiting, or lethargy. Um, Seizures are also very common, as previously described. Spinal cord compressions. Compression can present with back pain, weakness of the legs, and bowel bladder dysfunction. In terms of the diagnostic criteria, oligodendroglioma-like morphology, OLIG2 and synaptophysin immunoreactivity, also chromosome 1p deletion, and MAPK pathway alteration. For unresolved lesions, methylation profile of diffuse leptomeningeal glioneuronal tumors seen on what is desirable in these types of tumors are a childhood onset and a leptomeningeal dissemination. Of note, this tumor type shows molecular overlap with pilocytic astrocytoma and oligodendroglioma, uh, P1P 19q co-deletion. All diffuse leptomeningeal glioneuronal tumors are wild type, and the IDH1 and IDH2. So grading and the pathology of these types of tumors, data for grading these tumors are limited. Most DLGNT are well differentiated low-grade tumors. However, most of these tumors have a low-grade histological appearance as well, with commensurately low mitotic index of less than 1% and behave fairly indolently. For cases of conventional DLGNT and DLGNT MC1, the behavior has been consistent with WHO grade 2 entities, whereas tumors with anaplastic features like one-Q gain and the DLGNT-MC2 profile have clinical course or suggestive of a WHO grade 3 lesion. These tumors histologically are composed of intense desmoplastic fibrous response admixed with cells with perinuclear halos and cytoplasmic swelling, similar to oligodendroglial cells. They have round to oval nuclei with finely granular dispersed chromatin and inconspicuous nucleoli. Radiologically, imaging is ideally carried out with the MRI, although CT will demonstrate many of the same features within its limitations. MRIs, the dominant finding is of thick nodular leptomeningeal enhancement, particularly around the basal cisterns and extending over the surface of the brain and spinal cord. A further finding, which is believed to be fairly specific for this entity, is the presence of numerous small subpial cysts, high on T2 and low on the T1. Flare is usually attenuating, located over the surface of the inferior parts of the cerebral hemispheres, posterior fossa, and spinal cord. It is thought that perhaps these represent dilatations of the perivascular spaces. Importantly to note, often no definitely dominant primary parenchymal mass identified here. In many patients, however, discrete intraparenchymal lesions can be identified, most frequently in the spinal cord. MRI usually shows diffuse leptomeningeal enhancement and thickening alongside the spinal cord with intracranial extension to the posterior fossa, brainstem, and as described, the basal systems as well. In terms of treatment and prognosis, stability or slow growth over many years may still produce significant morbidity. Decreased survival was associated with mitotic activity, a Ki-67 proliferation index of greater than equal to 4%, and a microvascular proliferation on initial biopsy. Although this diffuse leptomeningeal um, glioneuronal tumors demonstrate fairly indolent growth, morbidity is quite prominent due to profound hydrocephalus. Survival varies widely, reported in some instances to be quite low, with an average survival of only 22 months, whereas other series have no long follow-up. Moving on to the next tumor will be dysplastic cerebellar ganglioside tumor, DCG, which is a WHO grade 1 type tumor, also known as the ganglioneuroma of the cerebellum, Purkinjoma, and granular cell hypertrophy of the cerebellum, gangliocytoma dysplasticum, also hamartoma of the cerebellum. Right, this type of tumor is a cerebellar lesion with features of both a malformation and a low-grade WHO1 neoplasm that has a propensity to progress and recur after surgery. It may be focal or diffuse, and the cerebellar foliae are diffusely enlarged. This plastic cerebellar gangliocytoma, perhaps better known as the Leishman-Dicklos disease, is a rare tumor of the cerebellum appearing as thickening and increase in T2 signal of the cerebellar folia, giving the lesion a characteristic striated appearance. The DCG typically presents in young adults, although they have been encountered at all ages. They are autosomal dominant with incidence rates of 1 in about 250,000 live births. Most identified cases have been in adults, but patients as young as 3 years have been reported. Strongly associated with Cowden's syndrome, where the incidence is 1 in 200,000, associated with thyroid, breast, and uterine cancer, mucosal neuromas, and meningiomas. In terms of clinical presentation, uh, patients present with small tumors may be asymptomatic or only present with relatively subtle cerebellar signs, like, for example, dysmetria. When they are larger, symptoms are typically related to raising ICP, um, found in the obstructive hydrocephalus, and to a lesser degree, the cerebellar dysfunction. Typically, middle-aged adults with signs and symptoms of a cerebellar mass, such as dysmetria, or they may present with hydrocephalus, as previously described. It can also be incidentally found. Um, Cranial nerve deficits may be present in these types of tumors as well. In terms of diagnostic criteria, gangliocytic lesion enlarging cerebellar folia, densely packed ganglionic cells of various size, and matrix resembling normal neuropil, sometimes more coarsely fibrillar or vacuolated. Desirable in these cases would be the PTEN mutation/deletion or loss of expression, abnormal myelination and vacuolization in the outer molecular layer, and calcification and ectatic vessels. In terms of radiological evaluations, on CT, they may show a non-specific hyperattenuating cerebellar mass. Calcification is sometimes seen, and mass effect may be seen as well. On MRI, T1W1 hypo to isointense, and T2W1 hypointense heterogeneous, non-enhancing characteristic striated appearance due to widened cerebellar folia and may contain calcifications as well. DWI would be hyperintense with the ADC map being hypointense. On T1, it would again to be hypointense, T2 hypointense with apparently preserved cortical striations. On the T1 C plus gadolinium enhancement is rare. If present, usually superficial, possibly due to vascular proliferation. Sometimes spectroscopy can be done, right, which will show um, elevated lactate, slightly reduced NAA, reduced myoinositol levels by 30 to 80%, which reduce choline or reduce choline creatinine ratio. Uh, PET such SPECT scans can be done as well, which shows increased uptake, and T120 SPECT can show increased uptake. Of note, in a child with the MRI findings of, let's admit, Duclos disease, even if classic, a medulloblastoma is statistically more likely, especially medulloblastoma with extensive nodularity. In terms of treatment and prognosis, surgical resection is often curative, with only a few cases reports of reoccurrence. Shunting is performed for hydrocephalus, and biopsy is recommended for particularly for pediatric cases to rule out medulloblastoma. Um, in terms of the efficacy of radiation therapy, currently is unknown, the benefits of. And importantly, to note is crucial to remember the association with the Cowden syndrome, hence increased risk of other neoplasms such as breast endometrial and thyroid cancers. Therefore, a recommendation of further imaging or clinical assessment of possible tumors in these locations should be investigated. Moving on to multinodular and vacuolating neuronal tumors, MVNT, WHO grade 1. These types of tumors are rare tumors comprised of uniform neuronal elements dispersed in discrete nodules with vacuolar changes. MVNTs favor the temporal lobes and characteristically involve the deep cortical ribbon and superficial white matter. MVNTs are lesions with distinct cytoarchitectural patterns. They are often considered part of the heterogeneous group of tumors known as LEATs. Radiologically, MVNTs appears as small bubbly appearance and indolent subcortical tumors that sometimes present with seizures. These tumors have been most frequently identified in the temporal lobe, although that is likely due to that location being more likely to result in seizures than necessarily a predilection for that lobe. In terms of clinical presentation, seizures, usually to the presence of the leaning temporal lobe, temporal lobe epilepsy types appear findings. And also, you can find other neurological symptoms such as vertigo, paresthesia, dysarthria, cognitive impairment, and in some cases, even thunderclap headaches may be a common finding. And it could also be an incidental finding as well. Yeah, many cases are discovered incidentally during the imaging studies and are considered the leave me alone lesion, meaning they don't require the intervention. In terms of diagnostic criteria, it is usually modularity, neuronal cytological features, or tumor cell immunoreactivity for synaptophysin, or non-phosphorylated 200 kDa NFP and HUC/HUD. Also, the absence of mitotic activity, and lastly, tumor cell slash matrix vacuolation, but maybe minimal. What is desirable would be a immunoreactivity for OLIG2 and internexin E, absence of NEUN or the chromogranin expression, and lastly, the MAPK pathway activating abnormalities. In terms of the radiological evaluation, on CT, smaller lesions are difficult to be identified, but if seen well appear will appear as non-enhancing low attenuation lesions deep to the cortex in the subcortical white matter. MRI, these tumors appear as a cluster of well-circumscribed high T2 signals, which will show a bubbling appearance, located predominantly in the subcortical white matter, but can involve the overlying cortex. On T1, hypointense to adjacent gray and white matter in the gadolinium. Usually no enhancement. Some faint focal enhancements may also be seen, however, right? Um, in terms of T2, hyperintense to gray and white matter, almost as high as the CSF, and occasionally central hypointense dots. Also hypointense on the flemages as well. In the cerebellum, these lesions most commonly involve the vermis, often extending cerebellar hemispheres, but not the brainstem. In terms of treatment and prognosis, MVMTs appear to be benign tumors with very indolent biological behavior, which can, if symptomatic, be followed by imaging alone. If symptomatic patients present following a gross total excision, there are no reports of recurrence usually, and subtotally resected tumors have little documentation of progression. Moving on to the next tumor, central neurocytoma, usually WHO grade 2, uh, usually central, okay, are rare WHO grade 2 neuronal tumors. They are generally attached to the septum pellucidum within the lateral ventricles and less frequently occur within the third ventricle. The most common presentation is with the increase in intracranial pressure and ventricular megaly. Due to an uncertain relation of prognosis to Ki67 index and anaplastic features, a distinction between a possible grade 1 versus grade 2 has not been yet made. Um, it constitutes 0.1 to 0.5% of all brain tumors with an incidence peak in the third decade, but they also present in children and elderly as well with no gender predominance. If MIB1 labeling index is greater than 2 to 4%, there's an increased risk of recurrence after subtotal resection, sorry. And if MIB1 labeling is elevated, radiation therapy after subtotal resection can reduce the risk of reoccurrence. They are typically seen in young patients and generally have a good prognosis provided complete resection can be achieved. Extraventricular neurocytomas, previously known as the central neurocytomas, are very common, as we will describe next. Right. Uh, Clinical presentation, you typically presents with symptoms of increased ICP, headaches, and seizures. Yeah, especially tumors with extraventricular extension. Rarely, these type tumors may be associated with sudden death secondary to acute ventricular obstruction. They are also rare and is a sudden presentation due to intraventricular hemorrhage. Um, with regards to increased ICP, uh, central neurocytoma can obstruct the intraventricular foramen, leading to hydrocephalus and symptoms related to. Patients can also present with visual disturbances, mental status changing, in terms of memory problems, confusion, and personality changes. Seizures, nausea and vomiting, weakness, or loss of sensation in some cases. In terms of the diagnostic criteria of central neurocytomas, what is essential is the intraventricular localization, oligodendroglioma-like monomorphic cells, and synaptophysin expression. For unresolved lesions, methylation profile of central neurocytomas can be found. What is desirable for these tumors are young adult patients, and in most cases, no signs of malignancy. Um, in terms of radiological evaluation of these patients, CT of these scans are usually hyperattenuating compared to the white matter, and calcification is seen in over half of cases, usually punctate in nature. Cystic regions are frequently present, especially in the larger tumors. Contrast enhancement is usually mild to moderate, accompanying ventricular dilatation is often present as well. In terms of MRI, on the T1, it can be iso-intense to the gray matter and heterogeneous. Um, and T1, C plus, mild to moderate heterogeneity enhancement might be seen. T2, as well as flare, is typically iso to somewhat hyperintense compared to the brain parenchyma. Numerous cystic areas, such as bubbly appearance and Swiss cheese appearance, many of which completely attenuate on the flare. Prominent flow of voids may be seen. On the GE slash the SWI classification is common, typically punctate hemorrhages, especially in larger tumors. It is common and uncommonly result in ventricular hemorrhage. DWI, diffusion restriction of the solid component, and MR spectroscopy may have a strong choline peak, glycine peak, and have also been reported. Some of these patients get DSAs, which showed sometimes a tumor blush um, with the mass supplied by the choroidal vessels. Also, no large feeding arteries are usually seen on these imaging. Treatment and prognosis. So in terms of treatment, total resection is most often curative, and after gross total resection, radiation therapy is generally not necessary. Subtotal resection can be followed by stereotactic radiosurgery, especially if MIB1 labeling is greater than 2 to 4%. Chemotherapy for recurrence and inoperable tumors has been reported with many agents, including the alkylating agents, platinum-based agents, etoposide, and topotecan, and vincristine. After treatment, patients should have long-term follow-up imaging as surveillance for tumor recurrence. In terms of patients' prognosis with these types of tumors, total resection, as previously described, can be curative. Recurrence risk after subtotal resection varies with the MIB1 labeling index. And in a case in 2004, with the aforementioned labeling, um, local control rates after subtotal, the 5 year, sorry, local control rate after subtotal resection alone was approximately 7%. But if subtotal resection was followed with radiation therapy, as high as 70%. Yeah. Moving on to the extraventricular neurocytoma. This is a WHO grade 2 type tumor. These are previously known as the cerebral neurocytomas, and they are rare WHO grade 2 primary CNS neoplasms, usually arising in the cerebral hemisphere, located in the cerebral parenchyma, cerebellum, thalamus, brainstem, pineal regions, and spinal cord. They can be focally infiltrative into surrounding tissue, um, FGFR1 to TACC1 fusions are frequently identified. In terms of clinical presentations of these types of tumors, they're usually non-specific type tumors, and similar to the previously mentioned tumors, The clinical presentation of EVNs often non-specific, meaning the symptoms are not unique to this type of tumor, but can be caused by other conditions. Patients can present with headaches, seizures, focal neurological deficits, raised ICP and associated symptoms, and even changes to vision, balance, memories, and personality. In terms of diagnostic criteria, um, what is essential here is extraventricular neurocytic neoplasm with IDH alteration and synaptophysin expression. For unresolved lesions, methylation profile of extraventricular neurocyte tumors. And what may be desirable is that OLIG2 immunonegativity, loss of ATRX expression, and diffuse P53 immuno um, positivity. So of no diagnosis should be heavily weighted towards molecular findings because morphological analysis frequently results in mistyping. Radiologically, lesions tend to be generally circumscribed, complex, and sometimes large. Um, large, complex, and variable enhancing masses. They are often partly or mainly cystic, with calcification not being very common. They may or may not be associated with peritumoral edema as well. On MRI, in most instances, they are well defined, often mixed cystic heterogeneously solid lesions that involve deep white matter or the cortical gray matter of the cerebral hemisphere. On T1C plus, solid portions may show varying degrees of enhancement. Treatment and prognosis. So the overall prognosis with this low-grade tumor is favorable. Um, the rate of recurrence has been low. Seizure control has been good following gross total resection. As these are relatively indolent and well-demarcated tumors, complete surgical resection can effect a cure. CSF dissemination is reported, but is quite rare. Moving on to cerebellar liponeurocytoma, which I believe is the last one, yeah. Formerly lipomatous medulloblastoma, a rare WHO grade 2 neoplasm with neuronal slash neurocytic differentiation and clusters of neoplastic neurocytes with lipidization that occurs exclusively in the cerebellum, typically in the cerebellar hemispheres, with less commonly found in the midline of the CPA of adults, and then there's a mean age of 50 years old. No gender preference are seen with these types of tumors. Some authors suggest that more inclusive name liponeurocyte tumor should replace the separate WHO classification of the cerebellar liponeurocyte tumor. Others contend that supratentorial exceptions are central neurocyte tumors which contain neurocytes that underwent lipidization instead of having actual adipose metaplasia. These types of tumors have been reported at a wide range of ages 4 to up to 77 years of age, but seem to be encountered typically in adults of middle age. There is no strong gender predisposition as previously mentioned. Clinical presentation of these types of patients are usually symptoms of cerebellar dysfunction, such as ataxia, gait disturbance. Um, Patients can present with symptoms of raised ICP, such as the headaches, vomiting, visual disturbance, dizziness. The other manifestations could also include dysphonia, flow obstruction of the cerebrospinal fluid, as we previously described, and the symptoms associated with such. In terms of diagnostic criteria, what is essential is a cerebellar localization and oligodendroglioma, like monomorphic cells associated with focal lipoma-like changes, synaptophysin expression as well, and for unresolved lesions, methylation profile of cerebellar liponeurocytoma. What may be desirable in these types of tumors found in adult patients, focal GFAP immunoreactivity, and the absence of histological features of malignancy. In terms of radiological evaluation of cerebellar liponeurocytomas appear as heterogeneous intraaxial or uncommonly intraventricular masses. The most common location is in the cerebellar hemispheres. On CT, the tumor is usually hypodense, but occasionally isodense to surrounding parenchyma. On MRI, lipid-rich areas are hyperintense on the T1 and T2, and suspicion about lipid content is quite supported in these cases. T1 most commonly hypointense, sometimes isointense, and not occasionally hyperintense to suggest macroscopic fat. And T2 flare, usually hyperintense, and the T1C plus heterogeneous enhancement can be seen. Some of these patients got worked up with PET scans, which can show cerebellar liponeurocytomas, which demonstrate high C11 methionine uptake, but low F15 FDG uptake than normally brain contact cortex tissue. In terms of treatment and prognosis, cerebellar liponeurocytoma have a favorable prognosis. Following gross total resection, the 5-year survival rate was approximately 71.3%. And PFS rates 61%. The overall survival was 16.3 years, and the mean PFS was approximately 10 years. So total resection carried a 42% reoccurrence rate with 15% with gross total resection. Post-op radiation improves the PFS from 55% 55% to 92%, with a median follow-up of 52 months. All recurrences were restricted to the posterior fossa. And that brings me to the end of glioneuronal and neuronal type tumors.